Good evening, everyone.
Good evening.
Good evening, all, and welcome to this meeting.
Good evening.
Good evening. Mr. Ephraim, you are
Yes,
welcome to the meeting.
thank you very much, sir.
Without wasting time, we would like to start the meeting. Today, we'll be listening to one of our friends and the pioneer member of Aegis, Mr. Ephraim Samuels. Mr. Ephraim Samuels is a minimal invasive surgeon speaking from the UK. He is a consultant, obstetrician, and gynecologist with Sherwood Forest Hospitals, National Health Trust Foundation, Mansfield, United Kingdom. He is a minimal access surgeon with special interest in hysteroscopic and urogynecology. He obtained his MBBS degree from University of Jos and also did his residency in Jos University Teaching Hospital. He's a fellow of the West African College of Surgeons and a fellow of National Programming Medical College in Obstetrics and Gynecology. He is also a member of the Royal College of Obstetricians and Gynecologists. Mr. Ephraim has actually been with us, and he's a contributor in the Edges textbook of minimal access surgery, where he gave us a contribution on history of minimal access surgery. Tonight, he'll be speaking to us on the history of minimal access surgery. Mr. Ephraim, you're welcome.
Thank you very much, sir. Good evening, everyone. It's a privilege to be here to share my experience and also my contribution to minimal access surgery. And I hope that at the end of the day, we will have a good appreciation of where we were and how the journey started up until where we are now in the practice of minimal access surgery. Without wasting much time and thanking you for that introduction, I would like to proceed. I hope we can see the slide. Yeah? Okay, thank you.
Yes, we are seeing
Yeah.
your slide.
Okay, so the history is like a journey from when things started in era where we had limited equipment and instruments for surgery, and people focused on open surgery because they felt that that was the approach to go. However, currently we have progressed beyond that. We went to diagnosis, we went to operative, we've now come to robotic, and impressively, we are looking at telesurgery with emphasis on operating across continents. I have put this in because I was one of the authors for the chapter on the minimal access surgery of our textbook, which is a privilege, and I thank the AGES members for this opportunity. The discussion will follow this outline, and the reason why I feel the history is very important is because we only know where we are going to, and we're well prepared for it if we know where our journey started from. And that is why we're able to progress in the future by standing on the shoulders of giants. I will look through the introduction, we'll look at a few definitions, go through the chronology of how we started in the early days and how we progressed to operative, arrived at robotics, and where we are in Nigeria. And we will briefly look at what the present challenges and possible future is for us in minimal access surgery. We started with larger incisions on the human body because we felt that we will have good success when we make a bigger incision. And that is why you see a surgeon making an incision on the abdomen that we usually describe as Cairo to Cape Town, from the xiphisternum down to the pubic symphysis. But this has been clearly challenged by minimal access surgery because we have come to realize that our outcomes in terms of recovery and pain is a lot better when it comes to minimal access surgery. And that is why we have arrived at the destination we're in. If we are looking at the peritoneal cavity, we describe that as laparoscopy. Looking at the bladder, cystoscopy, and of course, looking at the uterine cavity, hysteroscopy is what comes to our mind. So based on the body cavity that we're dealing with, the name for the procedure has been designed to give us insight into what is going on. When we perform our minimal access surgery, we use small incision. And to visualize properly, there is the need for a camera system to help us appreciate what we're looking at. When we do things this way, we minimize trauma to tissues. Of course, our recovery is shorter. The pain we experience after surgery is less because we are going to be feeling pain around a very small incision. And we're actually able to achieve a very good outcome, if not better outcome, compared to open surgery, depending on the situation that we're dealing with. It has been interchangeably described as minimally invasive surgery, keyhole surgery, or laparoscopic surgery. These are all referring to the same thing. I know currently in our practice, a lady comes to see us in clinic and we need to do a speculum examination. That actually was the beginning of our journey when Hippocrates used a speculum for rectal examination in an individual who had intestinal obstruction. This is as far back as 400 BC. In Pompeii, vaginal examination was documented in 70 AD, and even in 300 AD, this was documented in Babylon. By the time we were approaching the 1585 era, the first documentation of light source innovation was described when an individual called Arazzini was able to use sunlight to examine the nasal cavity. So I think we can say that that was the beginning of a good light source for visualization. By the time we're approaching the 1706, trocar was designed, and by 1912, we now had a contemporary design of what we use to gain access into the peritoneal cavity. Visualization of internal organs in humans using reflective mirror actually came about in 1806 with the aid of a candle. Philip Bozzini was the one credited for this. Minimal access surgery had a good foundation which began properly in the early 20th century. George Kellen actually did the first experimental laparoscopy when he was able to visualize the abdomen of a dog that was bleeding. That same year, Dimitri pushed the limit further and he actually was able to examine the abdominal cavity of a pregnant woman. And what he did was to use head mirror to gain access through the posterior fornix where an incision was made to visualize the abdominal cavity. So technically speaking, you could say that he created or innovated the natural orifice trans-illumination endoscopic surgery. So he can be regarded as the father of the notes, or for gynecology, we can say the V note, where V stands for the vaginal approach. Hans later performed the first human diagnostic laparoscopy. However, things were still quite primitive, which was why we were limited to diagnosis. And that was probably due to the poor lighting challenges, which impaired visualization. Progress was made, and there was advancement in fiber optics and video technology, and we were able to successfully enter the era of operative surgeries for our minimal access approach. SAMS first performed laparoscopic appendectomy, and we can comfortably call him the father of operative laparoscopy. Um, Things continue to improve, and the general surgery aspect was revolutionized when Erich did a laparoscopic cholecystectomy. 4 years down the line, we had access to devices that were able to cauterize tissue, staples, and finally, suturing came into the scene. This actually opened up the history of our skills to modern minimal access surgery that included both diagnostic and operative approach. As time went on in the early 90s, there was a huge explosion in laparoscopic surgery because of how the outcome was really good, the short recovery, the less pain that they experienced. A lot of patients started going for a laparoscopic approach or minimal access surgery. I still remember during my training when we have our morning meetings to discuss patients that have been admitted and all of that. And one thing that usually comes on when PID is mentioned is laparoscopy is the gold standard. All this played nicely into how we have progressed from diagnostic up until this point. So a lot of surgeons and doctors were now encouraged to adopt minimal access surgery approach for their surgery. And things continue to progress in terms of general surgery like cholecystectomy and appendectomy, even for gynecological surgeries like diagnosis and some minimal benign gynecological laparoscopic surgeries. Now, we have looked at how laparoscopy has come through up until this point. An important key component to minimal access surgery is hysteroscopy because it gave us that opportunity to look into the cavity of the uterus. We were able to directly visualize the uterine cavity, removing that component of abdominal incision, and this gave opportunity to treat and investigate situations like infertility and abnormal uterine bleeding. It not only went into a diagnostic approach, but also operative, where polyps and fibroids can be removed and septum in the uterus can be separated to improve the chances of our patients. Pandaleone was able to cauterize a bleeding uterine lesion, so we can confidently say that he performed the first combined diagnostic and operative hysteroscopy, and he was actually good at it with good success. As time went on, there was a need to be able to see the cavity properly through distension medium, and that was where our carbon dioxide distension medium came in, and our irrigation system came in, where we have now established the use of normal saline, for example, as our uterine distension medium to enable visualization. And depending on if we're going to do more, other distension medium have been introduced. We also progressed into illumination properly for better visualization and moved away from candles and reflective lights into what we now have as our ultimate fiber optics. Now, the instruments, when they were first designed, were on the bigger side, and the uterus is small, especially in our menopausal women. Therefore, there was a need to redesign the hysteroscope, and we were able to successfully reduce the size and improve functionality to ensure that we had the component of diagnosis and operation at the same time when we perform hysteroscopic procedure. Operating channels were introduced into a hysteroscope, and it now created an opportunity to not only use a hysteroscope in theater, but also in the outpatient setting. I run an outpatient hysteroscopy clinic in my trust where I work, and I am able to successfully take out polyp, do biopsy, retrieve coils that are missing, all with either gas and air, local anesthetic to the cervix, and that removes the challenge and the risk of general anesthetic if they are taken to theater. So basically, we have shrunken the size of the hysteroscope to a point that we have not only made it safe to perform surgery, but we've also taken away the risk of anesthesia. Now, this has given us very good fertility outcome when we investigate and perform this surgery, giving our patient a very good satisfaction and minimizing morbidity that comes with surgery. The next important thing I'd like to bring to our attention this evening is V notes. So I'm sure we remember when we talked about the notes, during which Dimitri was the one that we can credit for notes. Now, V note came into clinical practice in the early 2012, and it has the advantage of being um, a procedure that combines a laparoscopic components with use of instruments. So you are able to go in through the vagina. You're able to get good visualization as you would if you're doing a laparoscopy, but with no incision on the abdomen. So it's been described as a scarless minimal access surgery for individuals or situations that merit the criteria for this sort of procedure. It has clearly been used for hysterectomy. I have special interest in urogynecology, and I've seen it being used. I'm actually preparing to go for further training in Europe for this. I've seen it being used for vaginal hysterectomy, where you take the uterosacral ligament, insert the device, and the rest of the procedure is practically done as if you are doing a laparoscopy, but from the vaginal route. You don't have to put an incision on the abdominal wall. You're able to see the adnexa clearly. If there's a cyst, you can do a cystectomy, or if you need to do a bilateral salpingo-oophorectomy as you're doing the hysterectomy through the vagina, you can perform the procedure at the same time while you're taking away any risk or any challenge for an abdominal incision. In Europe, which is where most of the trainings for VNOT is currently taking place, they have designed a structured training program and it's currently being well received. And hopefully, by the next few years, a lot of the vaginal and urogynecological surgeons will be performing this procedure in the UK. And of course, it will be an opportunity to bring these skills and technicality back home to Nigeria to develop our services. Robotic is the next important journey that we are taking as we discuss the history of minimal access surgery. It came into being in the early 2000s and it was able to create an opportunity where the precision is amazing, taking away that surgical tremor that some surgeons have with very good visualization. It's designed in such a way that you can have a very good 3D visualization of what you're doing, and it's able to navigate through angles in the pelvis that will be difficult to approach when you're using the standard 2D laparoscopic surgical approach. It provides you with that dexterity. The robot does majority of the work while you do a little bit less, but you're able to achieve fine procedure as you progress with this. Now, commonly it is used in urology for removal of the prostate. Gynecology, for example, myomectomy, hysterectomy, and as a urogynecologist, couple suspension is what we have been clearly demonstrated to use this for. Sacrocolpopexy to support the vaginal vault to the sacrum is another aspect where robotic is very, very important and comes in handy. In the past, when stress urinary incontinence was managed with the transvaginal tape, um, things were all good until complications started coming in, and I've worked in a mesh center in Nottingham where meshes are removed. You're able to do these procedures laparoscopically and also with the robots when you are able to identify clearly the plane and tease out the tissues until the mesh is completely removed. Robotic is amazing in this aspect when it comes to gynecological surgery. Of course, we cannot forget cardiothoracic surgery and colorectal, as well as the input that the robotic surgical approach has got to contribute. The surgery that involves suturing is an amazing thing that is clearly demonstrated when you use the robot because it gives you that dexterity to be able to do this over a long period of time. Your shoulders being tired and all of that reduces because the robot is taking on a lot of this. In Nigeria, we have a very gradual but good development of minimal access surgery initially, but now we are on a very high trajectory. Initially, we had most of our minimal access surgery in the private setup. However, this has expanded into our government hospitals as well as tertiary centers. We were limited to diagnostic at the beginning, but now we are moving slowly into operative minimal access surgery in the government hospital, while the private hospital has gone a lot ahead of the game. I remember when the first laparoscopic appendectomy was done in Jos by one of my trainers, Dr. Bashiru Ismaila. It was like a miracle. Everyone was amazed at what he could do. But that is how it's all started. One laparoscopic procedure done. in the hospital continue to build up until where we are right now. I am very proud to say that we have gone beyond our operative laparoscopic surgeries for benign gynecological condition or hysterectomy to robotic. And I saw recently online where we were displaying our first robotic gynecological surgery, and it was actually being labeled as one of the first in West Africa. It's happened in Lagos. It's happened in Abuja Nisa Premier, thanks to Dr. Wada and co. And things I believe will continue to progress. Yes, I know we are still at the early stage of our development, probably because of the costs and the way we can partner with companies to generate funding plans and all of that. But I can see Nigeria taking the world stage and being the standard for everybody else to emulate because we do have the resilience and the desire to get trained and make important difference wherever we stand. It will require specialized training, which we can access when we collaborate with different companies. And at the end of the day, what we bring back home actually will be a very good opportunity for better outcome for our patients while minimizing the pressure and the fatigue from prolonged surgeries. The future of minimal access surgery has gone beyond operating by the side of the patient to operating from a distance. China documented liver resection using satellite-based connection and algorithm to ensure that there was not much delay between the surgeon and when the patient is. And Belgium clearly has gone ahead to demonstrate that with better latency period. They've gone as far as transcontinental robotic bariatric surgery, where someone was in France operating in someone in India. That clearly has demonstrated breaking grounds on geographical barriers and gone far ahead. As our internet services continue to improve and as we continue to ensure that we have good access and collaboration and networking with our colleagues all over the world, I see this happening in a seamless way in the nearest future. Yes, we are faced with the problem of costs. How do we maintain this thing? Do we have good insurance for replacement of the various parts of the instrument? There are going to be instances where we will have robots in the tertiary centers and probably have nothing in the other little hospitals. But if we're able to work together as a team, work with the governments, build up our training experience, and work closely with public-private partnership, I can tell you that we're going a long way to establish ourselves in the world map. We have very good collaboration from AGES. The Royal College members are available for everyone. We have very beautiful and amazing curriculum from the West African College of Surgeon and the National Postgraduate College of Surgeon with support from SOGON. I can tell you confidently that we started our journey in the early 20th century worldwide when it comes to minimal access surgery. We've gone beyond diagnostic into robotic precision surgery, and now we are looking at telesurgery. Hysteroscopy has gone further and further with more little smaller instruments in such a way that we're able to perform surgery in the outpatient setting. I can say confidently that Nigeria will be there soon and will become the talk of the world as we continue to progress in our development for minimal access surgery to ensure that our patients get the best out of us. With this, I will bring my talk to a conclusion and I will hand over to my host. Thank you.
Thank you very much, Mr. Ephraim, for that very, very interesting package. He has taken us through the evolving stages of minimal access surgery from beginning to where we are presently and our projection for the future. Thank you. I don't know whether anybody has any question to ask. If there are no questions in the chat, then call it a day. Maybe I will allow my president to just make the final comments. Thank you.
Well, beautiful presentation. Mr. I used to call you doctor, but I know in the UK, once you become a fellow, you now become a mister. And I say that's how life probably is. You are born, you are called a master. You grow up, you get married, you become a mister. Go to medical school, you become a doctor. Go back and become a master again, and then back to being a mister. So congratulations on going throughout the entire cycle. Thank you very much.
Thank you.
Like you rightly said, yeah, minimal access surgery is still way behind in this part of the world, and we are trying to play the catch-up game. And we are hoping that with what we have on ground now, people like you and so many others in the diaspora, friends back home who are able to practice, teach, and impact knowledge, that we can catch people young. Okay, and that's what we're trying to do now, to bring in resident doctors to start early before they pass their exams, not just waiting for when they will have an update course that will last maybe 40 minutes or 1 hour presentation at most. So I'm happy that a lot of them have joined. Yes, we're just starting. So let's start with the history first until gradually we get to the most advanced form. But let me just quickly ask this question. In terms of acquiring the skills, how easy or how difficult it is? I don't know if you have any comment on that.
So, acquiring the skills for minimal access surgery, because we already have a very good foundation and we have very amazing teachers and trainers in Nigeria, which is our starting point. I believe this is achievable. I don't know if Prof will remember. I think I first met you in Ondo, Akure, during one of the Sogon meeting, where you took us through hysteroscopy. And that was where my journey
2000,
began. Yeah. So,
that's 20
yeah,
years ago.
exactly.
I'm really old now.
So
Yeah.
you can see that
Mm.
where I am now is from what I have experienced back then. So we have Professor Ikechebelu in Nigeria for laparoscopy. I went to him to learn the basics of laparoscopy. So it is very much available there in Nigeria. It is very much available for us to access the learning. And because of how our training is, we have a very good resilience built into us. And I promise you, if you apply that into your exposure, you will be able to pick up these skills easily. Ages, thank God to every individuals that has worked closely with the ESCOs is setting up, I don't know if I should be saying this on this platform, setting up an opportunity to sponsor individuals to go access training. There's a financial support for them. So you can see that those in diaspora, those within the country are working hard to create this opportunity. The challenge coming abroad is the cost. And I'm not going to pretend about it. It can be quite expensive to come abroad to come get this training. It would depend on the visa. It would depend on collaboration with the hospital that you're coming to have this exposure. And even when you come here, the hands-on aspect will be limited because you don't have occupational health or GMC clearance to touch the patient. So the best you might be getting in some of this opportunity will be to observe. So if we have our consultants, our trainers back in Nigeria who are already doing this thing in the private sectors and we can access them with support from ages, I think that we are heading in the right direction to become international stars.
Thank you very much. Thank you for that. Dr. Fachi, you want to add anything?
No, I mean, I just wanted to thank Dr. Mr. Ephraim for, for his time. It was a lucid presentation. I think it's a good start and appetizer for the residents. So, with the energy that Professor Jude has brought into this, I'm sure there is a lot more to come. And so, those who are really serious will get they are in for a good deal. So I encourage each and every one of them to make out time to join this webinars, because it's actually, I mean, it's invaluable. It's an invaluable amount of knowledge. So thank you for this lucid presentation.
Thank you.
Thank you.
Yes.
Thank you.
Thank you very much. Before we go, let me quickly make this announcement. Myself and Dr. Fachi, our Secretary General, joined about a minute late because we had a prior meeting before this where we had to rub minds with some of our colleagues who are based in the diaspora regarding what can be done, the principles, the practice, the syllabus, and all, so that WhatsApp group, by the grace of God, people will benefit immensely from it. I'll be announcing what we have decided, but I think in a nutshell, we are still not there yet because so many people who are on that platform might not be resident doctors. So we may have to send a Google form link. We need to be sure we are dealing with the people, the target audience. So that's resident doctors. And the whole aim, like I said, is such that when it's time for your normal update course, if they call me or call anybody else, just go in there to revise, not to tell you things you never heard of before. So we need to be sure of the people we are dealing with. So expect a Google form link that will be at some point for us to know who is who, which institution do you belong to, what's your rank and all that. And same thing with even our nurses as well. So we are sure we are dealing with the right group. And hopefully if we start early like this, in the next 2-3 years, we would have had a large number of Nigerians, of course, O&G, nurses and all, who have access and who have what it takes to at least say something and do something to minimum access surgery. So thank you very much for joining us. I'll hand over to Dr. Felix Agu to conclude so we can go. Dr. Agu, are you still there?
Thank you very much. Thank you very much, my president. I used to appreciate everyone, Mr. Ephraim Samuels, for that lucid presentation. Thank you, all the participants, for attending. And good night.
Thank you very much. Thank you.
All right. Thank you.
Thank you, Prof.
All right. Take care. You're welcome.